Afternoon, and is it shared? I think it will Kumar.
Yes. Just make it full screen.
Okay, okay. Good afternoon, friends. First of all, I'd like to thank Dr. Sudipta Mitra for giving me this opportunity. Today, I'm going to discuss the mistakes that I've made over the 26 years of my practice and the steps that I do now to make it successful. So, as Dr. Mitra has already discussed, we need to protect the endothelium in all cases. It's very important. We need to have an incision. I always prefer an incision, which is a posterior limbal, because there's a less chance of wound burn. The patients are happy and comfortable in the post-operative period, and the healing is better because of small amount of oozing. Conjunctival ballooning is an issue, but it can be easily taken care of. Staining is very important, as she has already discussed. And we always look for a large rhexis. We try to have a rhexis which is 5.5 to 6 millimeter in diameter for better visibility, less stress on the zonules, less chance of damage to the rhexis as we negotiate, and try to remove a large nucleus and less chance of papillary block. Hydrodissection is very important. Since you have got a large nucleus and a very little space within the bag, you'll have to give multiple small injections and not a large bulk of injection at a particular point, and tap the center after each injection so that there is no blowout fracture on the posterior capsule. Posterior capsule is already thin and it's quite old. Rotation is something I always do. I start with a bimanual rotation, like the way I'm doing here, and then I rotate it another 4 or 5 times with a single hand to make sure that the nucleus is free from all attachment from the capsule. I always try to choose a chopper which has got a large tip like this, which has got 1.25 millimeter tip, the Chang vertical chopper, and a Nagahara chopper, which again has got a large tip. And the choice of Feco tip are the bent tips because they give a better hold. Now, about the technique that I normally follow in hard cases, stop and chop is the preferred technique which I've been using. I make sure that the Feco tip is exposed more, about 1 millimeter. The central nucleus is first clean, epinucleus is removed to have a very clear view. I do a very deep trench to start with. I widen the trench so that the Feco tip can glide easily within the trench. I try to see the red reflex if it's possible. If it's very hard, it's difficult to see the red reflex. Rotate the nucleus by 180 degree and then continue with the trenching. After having done the trenching, it's very, very important again to ensure a complete separation between the fragments. So this separation you should do in 2 steps. First, separate on one side, then again rotate it, and then do the separation. Make sure both the chunks are separated, and then you start your sub chop with a bit high parameters, that is quadrant removal parameters. Here at this stage, I always use a hyperpulse mode because there's always a possibility of wound burn. You are using too much of power, you are using too much of Feco settings, and you are using high settings. Subdivision of fragments is very important. You should divide it into smaller pieces, and I want to emphasize that every time you divide the pieces, make sure they are properly divided, they're separated from each other, and make sure that these fragments do not bang on the endothelium or traumatize the endothelium, and hence you have to be cautious that you are away from the corneal endothelium at all stages. Viscoelastic vault is a very good technique which has been coined by Robert Steiner. As you do Feco, every minute you need to inject a very small amount of dispersive viscoelastic just under the cornea and a fairly large amount of viscoelastic above and below the quadrant, so that It acts as an artificial epinucleus. At the same time, it gives you enough space to work with when you are operating on a hard nucleus. Now I'll talk about a terminal chop technique, which I have started doing during the last few months. This is one of my few early cases. As you can see, I start from the center of the nucleus, do not go very deep, then try to hold the nucleus and then go to the periphery. And before going to the periphery, I slightly tilt the nucleus upwards. And then once I've done that, I do the other side, go from the center of the nucleus, as you can see, move towards the periphery, go deep but not deep enough, then pull the nucleus towards the center, tilt it forwards and complete the chop. This is a very, very good technique. It reduces the amount of phaco time that you require, but the only problem is if the nucleus is very hard, you can't actually perform it. It's difficult. It can cause a lot of stress on the zonules. Another technique which I had been using for the last 6-7 months is the submarine chop. It works well in moderately hard cataracts. The tip is exposure has to be a bit long. You need to have a long chopper. As you can see, you should start close to your incision, go deep in, make sure the tip as well as part of the sleeve is within the material of the nucleus, and then you chop the nucleus from periphery. Here again, you need to slightly tilt the distal end up, and that's how you can complete your phaco. Rest of the steps are same. So, and another thing I do in all my cases is I make up my mind that I'm going to be very slow. I do not use phaco power till the tip is occluded. I make sure the chunks are completely separated. I refill the antechamber with OVD. I used optimized power settings, that is moderate power, high vacuum, high bottle height, hyper pulse, and sometimes the burst mode. Wound burn is a possibility. You should constantly dribble BSS. Your assistant should constantly dribble BSS at the wound during the phaco. And if you end up with a wound burn, you'll have to convert to the extracapsular technique. So to conclude, hard cataract is a challenge, but it's not a nightmare. Good result can be achieved by adhering to the surgical protocol. You should be patient, you should be quiet, you should make up your mind that that's how we are going to negotiate the case, and you can easily take care. And as Dr. Sudipta has already said, corneal endothelial protection at all stages is mandatory. Thank you. Thank you very much for your patient hearing. I hand over to Dr. Sudipta Mitra for the rest of the IC.
Thank you, Dr. Arup sir. That was an excellent presentation with beautiful chops. I think we can take questions from others if questions are there. I would personally like to ask you, Dr. Arup sir,
Yes.
Since you've shown us two chops at the end, the submarine chop and the terminal chops, what is the basic difference in the phacofluidics that you maintain in these two cases?
Basically, in both the chops, I use almost the same parameters. A bit higher side vacuum. Flow rate is moderate at about 36, and the phaco power is slightly on a higher side. It's about 65 to 80%. And the basic difference between these two is for the submarine chop, you start close to the incision, go deep into the nucleus, almost if your tip is 1 millimeter exposed, you should also include the sleeve, which should go inside the material. Then you slightly tilt the other end up, the distal end up, and then you chop it. While in terminal chop, you don't have to go that deep. You start from the center, go towards the periphery, remain slightly under the level of the nucleus, and then pop up the distal end of the nucleus and then do the chop. The basic parameters are quite same.